So I'm going to talk about thyroid nodules and goiter. Can't move the slides on there, like that. Okay, great. So where's the thyroid gland? It's in your neck, as you probably know. And this is this drawing from this famous medical artist called Dr. Netter, who hung around and drew lots of anatomical and patient pictures in the 50s and 60s. So this is your thyroid here with a right lobe, a left lobe. It has this additional lobe, sometimes called the pyramidal lobe, which is part of the embryonic descent of the thyroid, because it comes from the back of your tongue and drops down into your neck. And it's closely wrapped around this grey thing here, which is your windpipe, the trachea. And then this thing above it, that's your Adam's apple. And then these are the carotid arteries, which kind of run behind the lobes. So that's where the thyroid is. It's really at the bottom of your neck, you know, between the Adam's apple and the top of your chest, just in there. Goiter is just a name for any enlargement of the thyroid gland, and it can be diffuse, as in this is another picture by the same medical artist, Dr. Netter, but this is a real patient with an enlarged thyroid, you can see, with a bulging neck, who was in my clinic a while ago. So it's a diffuse goiter, so both lobes of the thyroid are enlarged. And that can be caused by several different things. Probably in the world, iodine deficiency is the leading cause of a diffuse goiter, and that's sometimes called endemic goiter, meaning it's in the population in a certain country, largely confined nowadays to places like the Himalayas or some places in Africa, like the Rift Valley, where people have iodine deficiency. The Andes is the other place, although I think that's largely been addressed. Hashimoto thyroiditis is really common in 5 to 10% of women, and about 50% of people will have thyroid underactivity over time with Hashimoto thyroiditis, but that also produces a diffuse goiter. And in Hashimoto thyroiditis, the goiter is partly due to the raised TSH, so your pituitary gland is stimulating your thyroid to do more work, and that causes the cells to enlarge and hypertrophy to try and produce more thyroid hormone. But also the immune system is attacking your thyroid, and so lots of lymphocytes pile into your thyroid from your blood, and that also enlarges it. So it's like multifactorial in Hashimoto thyroiditis. The reason the gland is big. In Graves' disease, it's caused by stimulation, and it's almost always associated with thyroid overactivity, and then rarely with thyroid eye disease. And then there's this condition called simple goiter or colloid goiter, and that starts off often in young people around about the age of puberty, and it develops over time, grows bigger, and then by the time you get to the age of 70 or 80, often you've got nodules from that background of a diffusely enlarged thyroid gland. So those are the common causes of diffuse goiter. And so this is pictures of ladies in the Himalayas with endemic goiter. They've all got these pretty huge thyroids due to iodine deficiency. So what's interesting is in this population, iodine deficiency is really common, but actually thyroid underactivity is comparatively rare. People tend not to get it. So the compensatory increase in the thyroid is enough to stop these people going underactive. So this is some other, so if the thyroid is not diffusely enlarged, you have a nodular goiter. So this is a patient with probably 3 big nodules in the thyroid here. And this is a lady who probably just had 1 big nodule in the thyroid there. So that would be a nodular goiter. And so you need to understand a little bit about what the thyroid looks like under the microscope to understand what would form a nodular goiter. So I quite often say the thyroid gland is like an aerobar under the microscope, in that there are bubbles. And so the bubbles actually in the thyroid gland are filled with this pink material, which is called colloid, which is kind of sticky when you stick a needle in it. It looks like you've looks like you've taken some super glue or something. It's like shiny and sticky, but that contains all the preformed thyroid hormones that your thyroid gland will make. And these cells, the little purple cells, these are concentrating the iodine out of your bloodstream and converting it into thyroid hormone just at the boundary between the pink stuff, the gloopy colloid, and those cells. So that's where the thyroid hormones are actually made. And this is like a storage pool of thyroid hormones, and a healthy thyroid is full of these big follicles filled with this stuff called colloid. And so, yeah, T4 mainly about 15 parts of thyroxine to about 1 part of T3 stored in that colloid space. So what causes nodular goiter? Well, first of all, you can have a hyperplastic nodule, which is just lots of enlarged follicles. But you can also get cysts, which don't contain follicle fluid, a thyrocyst or a thyroglossal cyst. So these are both innocent, benign kind of nodules you get in the thyroid. Also follicular adenoma, which instead of being filled with colloid, this is more like a solid ball of cells. It probably does contain some colloid. And occasionally follicular adenoma can make thyroxine, and so that would be so-called autonomously functioning nodule. It's an area of the thyroid gland that's overactive, and it's a little benign tumor making extra thyroid hormones. And then thyroid cancer, and we'll come on to that. There are 5 or 6 different types of thyroid cancer, which we can talk about. So how common are thyroid nodules? It really depends on how you look. So if you just look at someone, you can sometimes see a moderate to large size thyroid nodule. And if you feel their necks, feel someone's neck with your fingers, roughly 2 to 7% of people will have a thyroid nodule, either visible or we say palpable, present to touch. And that's commoner in women than in men. If we do an ultrasound, though, depending on the age, roughly 50% of adults will have a thyroid nodule detected by ultrasound. Most of those are really small, less than a centimetre, but many people have larger benign nodules, which is just part of life. If you do a CT or an MRI scan, so-called cross-sectional imaging, so roughly 20% of people will have a visible nodule. But do note, even though people think a CT scan or an MRI scan is better, ultrasound scan is way more sensitive for detecting a thyroid nodule than these so-called cross-sectional imaging methods. And then lastly, this functional imaging. So FDG is fluorodeoxyglucose, so it's a metabolic scan. So you inject a radioactive glucose and it gets taken up by metabolically active tissues in the body. And that's normally used to stage people for different cancers. But about 2% of FDG PET scans will have a thyroid nodule. And the next slide just shows you an example of that. So this is a person having an FDG PET scan here, and you can see this is the neck. So those 2 little dots at the top are the activity in the normal muscles that hold the vocal cords open to allow you to breathe. But that is a hyperactive nodule. And up to 50% of nodules that are hyperactive on this kind of FDG PET scan will actually be thyroid cancer. So that's got the highest in terms of instantly discovered nodules, because it gives you some information that this is metabolically active. That's a pretty good indication to take this nodule seriously. On the other hand, this person on the left here, this is a person with Hashimoto thyroiditis, so they've got diffuse metabolic activity throughout both lobes of the thyroid gland, and that's the activity of the lymphocytes that are attacking the thyroid in that case. So you get different appearances depending on what, but a single or multiple little nodules like that on FDG PET scan always needs some additional investigation in general. So how common are thyroid nodules? Well, about 50% of women and 30% of men over 70 have nodules on ultrasound, but thyroid cancer incidence is really a lot less. So 95% of these roughly will be benign and only small, so 3 to 8 in 100,000 patients per year. So that's the number of fresh ones. Most nodules are small, as I've said, And then small thyroid cancers, if you do post-mortem, if you look at 100 post-mortems or autopsies, as they're known in America, small thyroid cancers, which are so-called papillary microcarcinoma, that means they're less than 1 centimetre. They're present in about 10% of people who have died of other causes. They haven't died of this cancer, they've died of a stroke or a car crash or something. But if you look at unselected postmortems, this is quite a common finding, that people have small cancers which would probably never have, well, which never did them any harm in their lifetime. And even if they've lived to 100, they probably wouldn't have done them any harm. So that's my doorbell going off, which is kind of annoying. This is just an example of what thyroid would look like with a papillary carcinoma. It's got this nodule in, and it's looking like that. And sometimes people with papillary cancer and follicular cancer have other nodules in the other lobe. So even though there's one that looks obvious, there may be others. So that's why we tend to scan before we go for surgery. So if I have a thyroid nodule, should I be worried? So these are the features of a nodule that might worry you. High-pitched whine on breathing. So your breathing is obstructed. That's called stridor technically. Sorry, I mean, you probably hear my doorbell in the background. Difficulty breathing, typically when you lie flat in bed. Recent onset hoarseness. So that means hoarseness of your voice when you haven't got a cold or a sore throat or something like that. Obviously, anyone can get hoarseness, but it's generally, if it persists for 2 or 3 weeks and there's no cold or anything, that's something to be concerned about, because that can mean it's affecting the vocal cords. If you have difficulty swallowing solids, that means your neck, your gullet, esophagus can be impinged on or obstructed by the thyroid nodule. That would typically happen in the thyroid nodule on the left. If there's recent rapid growth and you can really see that, or if there's enlarged lymph glands in the neck, some so-called lymphatic nodes, so that can also be bad news. So all these features would be consistent with cancer, and particularly if 2 or more of them are present, and we normally recommend a 2-week referral to hospital for all of these except for stridor. And if you've got stridor, you have to go the same day to the hospital in the emergency admission. So that's the features you might have, but also certain groups of people are more likely to have cancer. So thyroid nodules are really rare in young people or children, and so it's a lot more likely to be thyroid cancer if it's a nodule in a child or a teenager. And so we investigate that a lot more rapidly and take great care with those. Also, older men are more likely to be thyroid cancers. So even though numerically women have more thyroid cancer than men, thyroid nodules are relatively rarer in older guys. But if you've got one, it's more likely to be cancer than if you're a younger woman. If you've ever had neck irradiation in the past, you're more likely to get thyroid cancer. And that could be neck irradiation for a prior cancer, like a lymphoma in the neck, or sometimes people got it for tuberculosis in the distant past. They might have had neck irradiation to treat that. And then maybe almost self-evidently, if you've got someone with thyroid cancer in your family, you're more likely to have a bad nodule. But despite all these bad things, 95% of thyroid nodules seen on ultrasound are innocent and benign, and many of those don't need anything else doing about them at all. So although thyroid cancer does happen, it's not the commonest cause of nodules. In fact, it's relatively rare. So what tests would you need to have if you had a nodule? Well, ultrasound is not only the most sensitive way of finding a nodule, it's also the best way to tell whether it could be innocent or whether it could be nasty. So this nodule up here is a potentially nasty looking nodule. So it's darker than the surrounding thyroid tissue. This is a typical ultrasound kind of picture. And it's got these little white dots in, which are known as microcalcifications. Okay, so they're quite specific for thyroid cancer, and benign thyroid nodules rarely have microcalcifications. And there are a number of features you can pick up on ultrasound, such as irregular borders. If the nodule taller than wide refers to that the nodule is growing back into your body rather than upwards and down in the neck. And then, as I said, hypoechogenicity, that's the darkness of the nodule, and then absence of halo, which really means a capsule around the thyroid. So a good ultrasonographer can give you a very good idea of whether the nodule is innocent or not, or suspicious. And if the sonographer says it's innocent, you probably don't need any more tests, and it's probably a waste of time having fine needle aspiration cytology. So this will be the next test if the ultrasound had some of these features, and that would depend on how big the nodule was and how many of the features. But if it looks suspicious by these definitions, you would then go on to have fine needle aspiration cytology, which is a needle stuck into your neck, wiggled around a little bit, and then some cells are sucked out through the needle, and then they're spread onto a slide, and then someone looks at those down a microscope. This whole thing, fine needle aspiration, takes 5 to 10 minutes maximum. Normally it's not done with any anesthetic because the needles are quite small, quite fine, as we say. Having had that done myself, it took 5 minutes. They did 2 needles to me. You get a little nick, kind of sharp feeling when the nodule goes through the skin, and then when it goes into your thyroid, you get a different feeling, which is more like a deep, almost like a sickening feeling, but it's not exactly painful. It's not pleasant, but it's not pain, I would say. And then that's there till they pulled the needle out of the thyroid. So it's a funny feeling. I would say it's difficult to describe, so these are the ways we would look. And so the results of fine needle aspiration cytology is basically in three different categories. Roughly 1 or 2 means it's innocent and you don't need any more tests. 3 or 4 means it's suspicious of cancer, but it might not be cancer. And depending on whether you're here or 3A, 3F, or 4, it can be basically between 20 and 75% cancer risk. And then 5-5 means the cytologist says it's definitely cancer. And that could include all sorts of different sorts of thyroid cancer. We'll come on to those, but that would most commonly be papillary or follicular, but also lymphoma, anaplastic, medullary thyroid cancers as well would have this 5-5 category, which the microscopy person, the pathologist, would give. And so good signs on a thyroid nodule, so a Thy2, a colloid nodule benign, is you see lots of that gloopy pink stuff, the colloid. So you can see on the background of this is the colloid nodule. There are a few clusters of cells, not too many, and then there's lots of the gooey stuff, which is good. Whereas this one looks like it's come from more of a solid nodule. There's not so much gloopy pink stuff in the background, and there are relatively more cells. So that means the needle was stuck into a solid nodule, maybe. And there are so the cytologist can look at the nuclei of the cells to say if they're dividing rapidly, which would occasionally be a sign of cancer, and sometimes the formation. So you can see here there are some little circles of cells, and the pathologists call these microacini, which is just a technical term for little circle, but that can sometimes go along with a tumor. So that's the kind of thing they look for under the microscope. So this is, I think, from the British Thyroid Association thyroid nodule guidelines. So you start off at the top, you've got a thyroid nodule. And then you would go for an ultrasound, and depending if that's benign looking ultrasound, no follow-up required. If it's indeterminate on ultrasound with some of those features, maybe like the microcalcification or irregular margins, then you'll go and have the fine needle aspiration, which could lead to thyroid surgery, either therapeutic surgery, which would normally be take your whole thyroid out if it looked really like cancer, or if it's not clear what it is, sometimes you go for diagnostic thyroid surgery, which means they'll take out half of your thyroid so they know what it is. So under the microscope, there are 5 or 6 different sorts of thyroid cancer, papillary and follicular thyroid cancer. These are the 2 commonest cancers, and together these are called differentiated thyroid cancer, and the treatment is roughly the same for these sorts of thyroid cancer. And then there are more aggressive thyroid cancers, poorly differentiated or anaplastic thyroid cancer. So these are not good news, particularly anaplastic thyroid cancer, although really in the last year or two, even anaplastic thyroid cancer with molecular diagnostics, some people are getting better results from treatment. And thyroid lymphoma, that's a tumor of the lymphoid system occurring in your thyroid. And then this unusual tumor, medullary thyroid cancer. So that comes from cells that are in your thyroid, but they're not the thyroid hormone making cells. They're the cells that make calcitonin. And medullary thyroid cancer most commonly runs in families or has a genetic cause, which is in contrast to most of these other ones. So treatment for thyroid cancer, if it's so-called differentiated thyroid cancer, that's either papillary thyroid cancer or follicular thyroid cancer, you'll go for thyroid surgery first off. And if it's not 100% clear or it's a small tumor, they might do diagnostic surgery, which means normally a hemithyroidectomy, which would occur if you had a suspicious but not definite cancer on fine needle aspiration. And then if it turned out to be cancer on the hemithyroidectomy, then they would go on to do a completion thyroidectomy, depending a little bit on what it looked like under the microscope. But if your fine needle aspiration results show definite cancer, overall they'd probably go and do a total thyroidectomy first off, depending on the size of the tumor. And once again, depending on what everything looks like under the microscope, quite likely to be offered radioiodine therapy, and that would be these 2 things, surgery followed by radioiodine therapy, would complete treatment for most people. But people do rarely get recurrences of differentiated thyroid cancer. Overall, 5 to 10% of people, the disease will come back. It's not very common though. And then depending if it comes back just in the neck, you might be offered more surgery, or if it comes back with spread to different organs, the bone or the lungs would be the most common sites, then you can be offered some of these kind of inhibitory treatments, which is like tablet forms of chemotherapy to shrink the tumor. Medullary thyroid cancer is a bit of a category on its own. So it's really surgery is the mainstay of treatment. So you'd have a total thyroidectomy. They'd probably take the lymph nodes in the neck as well, because it tends to spread to the lymph nodes. And then in the last year, really, this treatment called selpercatinib, which is directed at the molecular cause of medullary thyroid cancer, has become available on the NHS. So if you have spread from medullary thyroid cancer, you may be offered this treatment, really something pretty new in the NHS, but it's very specific for medullary thyroid cancer and seems to have really good results. So the trials that went on for 2 years, more than 50% of people hadn't relapsed their disease in the 2-year observation treatment, hadn't had any progression. So it seems to be really effective at holding people's disease steady. And then thyroid lymphoma, that would normally be chemotherapy as the first line treatment, but sometimes radiotherapy depending on the sort of lymphoma. Thyroid surgery, what's it like? I had the misfortune to have thyroid surgery about 2 years ago now. So if it's a hemithyroidectomy, you might get done as a day case, but if depending on how old you are and what the hospital is like and how competent your surgeon is and how the operation goes, you might need 1 night in hospital after that. For a total thyroidectomy, it's almost always 1 night in hospital. Afterwards, the parathyroid glands and the nerves to your voice box go behind the thyroid, and so there's a small risk of damage to those, which is around about 2%, 1 in 50. So it's not very common. I found it a not very painful thing. I was on painkillers for 3 or 4 days. The thing I found surprising, which I didn't know about, was yawning was quite painful, because they cut the strap muscles surrounding your thyroid to pull it out, and you tend to use those when you're yawning. So that was a surprise for me. When I woke up, it definitely felt quite personal that I'd been kind of injured personally. And I didn't really expect that. It's definitely different from having an operation on your big toe where you can see and they go, oh yeah, look, they operated on my big toe. Just because the place it is, it feels they really operated on you. It's really a central part of you. It's not one of your appendages. And this was my scar a month after the operation. You can just see it there. And then 6 months later, it's basically gone. It's just a little white line there. Yeah, it's no big deal for most people. So yeah. So the main thing is choose a high volume surgeon. You know, you don't want to choose a thyroid surgeon who says, oh, that's very exciting. I haven't done a thyroidectomy for a while. You want someone who does them week in, week out, lots of operating. Okay. And this shows you the NHS GIRFT report. So GIRFT is an NHS program called Getting It Right First Time, which means people should see the right doctor at the right time for the right operation or the right treatment, getting it right first time. So this shows all the thyroid surgeons, I think in England and Wales, and how many operations they perform versus the complication rate. So most people should be discharged after 1 or 2 days of a thyroidectomy. So complications were defined as someone who had to stay more than 2 nights in hospital, or they were readmitted to hospital with the same problem within a month of the operation. Okay, so if you're a surgeon who does 1 to 4 thyroidectomies each year, it's about a 65% complication rate. Whereas if you're a surgeon who does 90 to 99 operations a year, the complication rate is less than 20%. In other words, most people, 80% of people, are out within 2 nights and don't come back into hospital. So this is based on 22,000 operations carried out in England and Wales. And based on this information, they define a cutoff of roughly 50 operations per year. Gives you a complication rate of less than 30%, and less than 50 operations a year. The complication rates tend to be more than 30%. And so you want a surgeon who's in this category by and large rather than that category. Yeah, so yeah, I don't know if I've got much else to say about that, but you should ask your surgeon how many operations they do, a month or a year. And these are the kind of figures you'd be looking for, something over 50. It's a good sign if people are on the same operating list as you, having the same operation as you. So if you have a thyroid nodule and it's not cancer, or what would be the reason to go and have an operation? So number one would be compressive symptoms. So if you had difficulty swallowing or breathing problems, that would normally be thyroid surgery as the first line choice. But for some very old people, sometimes we offer radioiodine therapy because that will shrink down the thyroid fairly well. It takes a bit of time, it takes a year, but people do get good relief if they're suitable from radioiodine therapy for a big compressive goiter sometimes. Also cosmetic concerns, if you've got a superficial thyroid nodule, you might say it looks pretty terrible, and sometimes it does look pretty terrible. So thyroid surgery will be offered then. The problem is you're swapping your nodule for a scar at the moment in general, and you could either have half or the whole thyroid removed, depending on whether it's just one nodule or if you have several nodules that you weren't happy with the look of. And then this new treatment, radiofrequency ablation, I'll talk about that. That was endorsed by NICE a couple of years ago, and there are probably 5 or 6 centres in the UK doing radiofrequency ablation for thyroid nodules that aren't cancer. But if you don't have compressive symptoms and you're not bothered by the appearance, then it's safe to do nothing for most thyroid nodules as long as the ultrasound shows it's innocent and it's not likely to be cancer. So this just shows you an older lady with a compressive goiter. She's got a huge thyroid nodule on the right there, and this is a CT scan. So you can see this is the top of the lungs, and we've cut her in half, and we're looking from the feet upwards. So that's the right-hand side over there. That's the left-hand side, and this is the windpipe. So the windpipe should be dead central in this position, and the windpipe is pushed way over to the left by this nodule in the thyroid, and so that's the kind of and that's quite a difficult operation because this is kind of deep down, or going into her chest and pressing on her lungs up here as well. So the surgeon depending on how big this is, what the next part of the scan shows, may have difficulty getting that out. But you can see there's some areas of calcification, so-called macro calcification in there, and that's a sign of an innocent tumor that's been there for a really long time to get calcified like that. So radiofrequency ablation, it's normally done by a radiologist. They insert an electrode into your nodule, and the electrode has an alternating current, and the alternating current induces heat basically, and you get some vaporization of the thyroid tissue. And so they will insert to the bottom of the nodule and then zap it, pull it back 2 or 3 millimeters, zap it, do that. So you get multiple little shocks. And sometimes that'll be 2 or 3 different sessions of treatment, depending on how big the nodule is. It can be painful to have this procedure. You can damage adjacent structures in exactly the same way as surgery. So not every nodule is suitable for this radiofrequency ablation. As I said, you may need multiple sessions, but this is one person who had that treatment. You can see you've got a pretty big nodule there, and that's a really good cosmetic result. So over 3 to 6 months, this treatment can really shrink a nodule. But in general, in the UK, we'd only recommend it on benign nodules, although in other parts of the world, they are treating some cancers with the same treatment. And lastly, I'm going to talk about autonomous thyroid nodules. These are the ones that are making extra thyroid hormones. So you have a scan like this, and you show an area of increased uptake. So you may get the typical features of thyroid overactivity, palpitations, tremor, heat intolerance, weight loss. And this is best treated by surgery or radioiodine, although they are starting to treat these with radiofrequency ablation as well. And these are almost always benign if you're an adult with this kind of functioning thyroid nodule, which is making more thyroid hormones. So the advantage of surgery in this case is you would just take out, for this person, the right half of the thyroid, and the left half would be left intact. And so the risk of thyroid underactivity for that person with a hemithyroidectomy is 5 to 10%. Most people won't need thyroxine replacement after that kind of surgery, whereas if you give radioiodine, it's probably a 40 to 50% risk of thyroid underactivity. So quite a lot of people opt for surgery because the risk of long-term thyroid underactivity is less. And so the last thing is, not every nodule in the neck is a thyroid nodule. So this is just a fellow who was referred to me, and the GP thought it was a thyroid nodule. I didn't do the scan actually; the surgeons did the thyroid nodule. But this was an office worker, and it back in the days when office workers always wore a tie. And you can see his thyroid. Well, number one, you can see the contour of his neck is abnormal with this nodule on the bulge on the right hand side. But this is his thyroid here, so he's had contrast here, and those are the blood vessels there, the carotid and the jugular. But this is his thyroid here, there, and this nodule is actually a fatty nodule. It's a lipoma. It's got the same black quality as the fatty layer underneath the skin. So he wanted to have that removed because it was annoying him, but it wasn't a thyroid nodule. So lipomas could occur anywhere. So to summarize, thyroid nodules are common, particularly in women. Most thyroid nodules are innocent and don't need treatment. Ultrasound is the most sensitive mode of imaging, but you do mainly treatment if it turns out to be thyroid cancer as detected by the imaging, and then normally by needle aspiration cytology. But also if you've got compressive symptoms, you may need treatment, and also if it's secreting thyroid hormones. So that's pretty much all I've got to say, and I'll stop sharing my screen.
Brilliant. Thank you, Simon. That was really, really interesting. So appreciate that. I just got a quick question, just about nodules, I suppose, in regards to if your nodule isn't causing you any problems, is it something that should be monitored, or do you just carry on with life and forget it's there?
Yeah, so if your thyroid nodule is not causing any problems and it looks innocent on ultrasound, then you can pretend it's not there and just carry on. I think if it has some suspicious ultrasound features, sometimes the recommendation would be to go and have a repeat ultrasound in 6 months or a year, just to make sure it's not growing rapidly. But normally we would give people that list of so-called red flag symptoms, which are rapid growth, change in your voice, development of neck lymph nodes, etc., compression symptoms, stopping being able to swallow, and just say if it changes and you develop any of those symptoms, get back in contact. But for most people, if it's innocent, it's going to stay innocent. And even innocent nodules grow by, a millimetre or two a year sometimes. So it has to be growing pretty significantly for us to get kind of concerned about it.